Picture this. You're in the hot seat. A trauma patient rolls in, they have major pelvic fractures, and right away, you notice blood at the urethral meatus. In a high-stakes clinical scenario like this, your very next move can literally mean the difference between life and a lifetime of catastrophic complications. So what do? Well, hold that thought. Welcome to The Explainer. I am so glad you're here with us today. Look, we are doing a rigorous audit of clinical decision-making. We're going to break down the exact pathways you absolutely need to memorize, so when the clinical judge is looking over your shoulder, you know exactly which way to pivot. Here's our mental map for today's explainer. 1. Nephrolithiasis and the size gate. 2. Hematuria and the voiding timeline. 3. Trauma and the hemodynamic pivot. And 4. Our executional pearl, the forbidden Foley. Let's jump right in. Module 1. Nephrolithiasis, the size gate. Okay, so here's your classic presentation. A patient comes in with severe, sudden onset flank pain radiating straight down to the groin. They're nauseated, they're vomiting, and you'll notice they just can't sit still. Unlike peritonitis, where the patient won't move a muscle, this patient is shifting positions, constantly trying to find relief. When you see this, the clinical judge demands an absolute audit of two things right away: the size of the stone and whether or not there's an infection. So let's look at the 50-50 dilemma, the size gate. If that stone is under 5 millimeters, you've got a really high probability of spontaneous passage. We're talking up to 80%. Management here is conservative. Aggressive hydration, NSAIDs, which actually work much better than opioids for that urodural spasm, and an alpha blocker like tamsulicin to help it pass. But if you cross that 10 millimeter gate, the probability of spontaneous passage drops to almost 0. You've got to pivot your execution toward a urologic evaluation for things like elective lithotripsy, ESWL, or a ureteroscopy. And looking at actual board scenarios, the source material completely backs us up. Acute management absolutely depends on the size and location of the calculi in a clinically stable patient. Small stones, fluids, and pain control. Big ones, you need intervention. But we do have to talk about the outliers, the staghorn calculus. These are typically struvite stones made of magnesium ammonium phosphate, and they are directly associated with urease-producing bacteria, think Proteus or Klebsiella. They form these massive stones in an alkaline urine environment, and the wild thing is they're often completely silent, but they are incredibly destructive to the kidney and require surgical percutaneous nephrolithotomy, PCNL, to safely remove. All right, let's do a signal versus noise audit. When a patient has a stone, hematuria is actually just noise. It's present in like 90% of all stone cases, so it doesn't really tell you how critical things are. But a fever plus a stone is a blazing red, high decibel signal. It means you've got an infected, obstructed system. That is a true urologic emergency requiring immediate decompression with a ureteral stent or a nephrostomy tube. And hey, please don't make this dumb mistake. Do not, under any circumstances, order an IVP or a CT with contrast as your first-line test. The contrast is going to light up the collecting system and totally obscure the stone. The absolute correct execution, the gold standard here, is a non-contrast helical CT. Module 2, hematuria, the voiding timeline. When you've got a patient presenting with blood in their urine, the exact moment that blood appears during voiding gives you a literal roadmap to their anatomy. Initial hematuria, blood right at the very start of the stream, points straight to a urethral source, like urethritis or a stricture. Terminal hematuria, meaning blood at the very end of voiding, strongly suggests the bladder neck or the prostate, think BPH or polyps. And total hematuria, meaning blood throughout the entire stream, you gotta look higher up, at the bladder itself or the upper urinary tract, like the kidneys and ureters. Back to our signal versus noise audit. If your patient describes smoky or cola-colored urine without any clots, that is extremely high signal for a glomerular source. We're talking nephritic syndrome. Clots, on the other hand, are technically noise when trying to pinpoint the specific etiology. They just tell you that there's a significant volume of bleeding happening, not necessarily where it's coming from. Which brings us to another potentially fatal error. Let's say a patient over 50 with a heavy smoking history walks in with gross, painless hematuria. Sometimes they might even complain of a little dysuria. Do not just brush it off as a UTI and send them out the door with antibiotics. Even if the urinalysis shows some bacteria, you absolutely have to rule out cancer. Direct visualization is non-negotiable here. For an adult with unexplained gross hematuria, especially someone with tobacco risk factors, a full workup including CT urography and a cystoscopy with biopsy is the most sensitive approach. It is your definitive diagnostic step to rule out bladder cancer.
Module 3. Trauma. The hemodynamic pivot.
When you have a patient with blunt abdominal trauma, your entire decision tree pivots on one single factor: hemodynamic stability. If they have a normal blood pressure and heart rate, they're stable. You have time. Go ahead and confidently send them for a CT scan of the abdomen and pelvis with IV contrast to check out those solid organs. But if their systolic blood pressure drops below 90, they are in shock. They are unstable. You do not go anywhere near the scanner. You immediately pull out the ultrasound and perform a fast scan right there at the bedside.
Here is your exact, non-negotiable algorithm for when they are unstable. Step 1. Fast scan. Step 2. If the fast is positive, meaning there's free fluid in the belly, they go straight to the operating room for an immediate laparotomy. Step 3. If the fast is negative, but they're still hypotensive and unstable, you have to hunt down that source of shock immediately. Are they bleeding into their pelvis from a fracture? Do they have a tension pneumothorax? You gotta find it. Quick signal audit here. If your trauma patient is complaining of left shoulder pain, pay close attention. That is Kelly's sign. It's a massive, high-signal indicator of diaphragmatic irritation, and it classically points to a ruptured spleen or massive free fluid in the abdomen. I want you to burn this phrase into your memory. CT scanners are the tunnel of death for unstable patients. Seriously, do not roll a hypotensive, crashing patient to the CT scanner just because you think the fast scan was kind of equivocal. If they are unstable and you even suspect abdominal bleeding, the only place they go is the OR, period.
Module 4, Executional Pearl, the Forbidden Foley. This answers the exact question we opened with today. Remember our trauma patient, major pelvic fractures, and blood at the urethra meatus? This is the classic pattern for a posterior urethral injury. The signs you have to know cold for the boards and the wards are blood at the meatus, a high-riding prostate on a digital rectal exam, the inability to void, and perineal ecchymosis. When you see this specific constellation of signs, there is one thing you must absolutely never do. The forbidden move is attempting to insert a Foley catheter. Why? Because if that urethra is only partially torn, blindly forcing a catheter in there can convert that partial tear into a complete, permanent, devastating transection. So what's the winning move? The definitive execution here is to order a retrograde urethrogram, or a RUG. Just like the source material dictates, you inject contrast into the urethra to visualize it and make sure it's continuous. You can only safely proceed with a catheter after the RUG confirms that the urethra is completely intact. We have covered a lot today: the stone-sized gate in metabolic flux, the voiding timeline for hematuria mechanics, that life-or-death hemodynamic pivot in trauma physics, and the absolute unbreakable rule of the forbidden Foley. These aren't just dry textbook facts. These are structural pathways that dictate clinical survival. So I'll leave you with this. The next time you're in the hot seat and the clinical judge is auditing your every move, will you know exactly which pivot point to look for? Keep reviewing these pathways, stay sharp out there, and I will see you in the next explainer.